हलवू नका म्हटलं.
Chitra, do you see YouTube live on? I mean, the message had come that we are live on the YouTube. Okay, because I am not able to see that.
No, I can see it. It is live on YouTube.
Just wait for. Good morning, sir. Jagdish bhai.
Good morning, Satish bhai.
It's 2 minutes past. We wait for a minute or so. Let others join.
Chitra has come to Baroda or she is in MI?
Chitra, tell sir.
Yes. Good morning, sir. So, I'm currently I'm in India, but I am currently in Goa. I had come for a week-long workshop for leadership in mental health at Sangat, which is a public health, mental health non-profit based in Goa. And so it runs this annual course called Leadership in Mental Health. So they have an in-person phase, which is 1 week. So we just finished it yesterday, so I'll be leaving for Baroda today.
Okay. Your voice was getting broken. Huh?
Oh, is it? This.
I could hear it well. I don't know.
Okay.
Maybe volume you can decrease.
Mm-hmm.
Are you wearing any this thing, earphones, Chitra?
No.
No. Okay. But I am able to hear you well.
Okay.
So I think we start the meeting. So good morning. Welcome back to Saturday Club meeting. Today we have Dr. Chitra Pandya with us to talk about integrating community-based psychosocial competence building with MBBS curriculum. Something new for all of us. Chitra is MD Community Medicine and has done Diploma in Community Mental Health at NIMHANS. She is founder and consultant for Medicine Beyond Classroom, Community Outreach Program of Varun Complete Healthcare. And she is also consultant at Kalpanam Center for Promotive and Preventive Mental Health at Varun Complete Healthcare. With this brief introduction, I request Chitra to start her talk. Chitra.
Good morning, everyone. So I will just share my screen and we shall begin right away. I would like to first of all thank you all for the opportunity to share my work on this platform. It is an honor for me, and I'm very excited to know your feedback. So, the way I'm going to proceed is it is a research that I'm basically going to present, the research project that I've piloted. But I've tried to modify the presentation a little bit to just make it more engaging rather than just a scientific research presentation. So, the overarching topic for today is innovation in community-based promotive and preventive mental health. And we are going to discuss just one specific part of this overarching topic. But, before we proceed with the specific research, I would like to orient today's audience to this initiative called Medicine Beyond Classroom, which I founded in 2019. So this Medicine Beyond Classroom was founded informal initiative, and the whole idea or the theory of change, so to time, that students are often disinterested in medicine and they don't view community medicine as a very interesting subject for various reasons. And so my idea was to engage medical students in community-based field projects with the aim that it would enhance their interest in the field of community medicine. And so when I was a doctor from 2018 to 2021 in community medicine, I wanted to be a brand of community medicine, and I still continue to feel the same. So I feel that community medicine has given a lot of opportunities to me to understand how our society functions and the social determinants of health. And this is my way of giving back to the subject. I want to be a ambassador for the subject and get more lucrative and more young students such take that up professionally. And over the past 4 to 5 years, it has evolved into a social entrepreneurship venture. It is not a not-for-profit, a for-profit. I aim to develop it into a self-sustaining model which can still continue to impact community-based mental health or promotive.
Chitra, your voice gets
So
broken.
our motto is
If
so
you're
to
saying rightly. Chitra, your voice gets, a little bit interrupted in between. I don't know whether you can do something about it. In between, few
unfortunately
words
the
are missed.
internet.
If nothing can be done, you can go ahead. We can read as well. That's no problem.
Maybe I can try switching off my video. That might help.
Yeah. Video you can switch off and then see. Yeah, please go ahead.
Let me know if it improves this, or then we can switch some other to look at other.
Still,
So
it
our
getting
modus operandi
interrupted.
for okay.
Speak
So
for 2-3 minutes. I will observe and then I will
is
let you
it
know.
okay if we take can we take a for a minute that I can
Yes,
switch?
please do that because only few words are heard and few words are missed.
Um,
Sorry
okay.
for the
So how
interruption.
can join?
Yeah. No, we can't hear you well.
Yeah, sorry for the error. Unfortunately, I not internet mobile, and you can navigate the presentation with you on email.
त्याला हात लावू नका फक्त याला हात लावू नका
Please wait. She's joining from other device.
This is my audio better now?
Yes, there is a echo. There is an echo, so you may please switch off one of the video audio.
Is this better?
Yes, Chitra, it looks better. Let us see.
Okay, yes. So I will now share my screen and hopefully we should be okay.
Yes.
Okay, so I will
Make
proceed.
it slideshow full screen.
I thought it already is.
We can see your other panel also. Yeah. Yes. Yes.
Is this better?
This is better. Yes.
Okay. So I'm sorry for the interruption, but we can now proceed. So our modus operandi for medicine beyond classroom is to integrate three separate but very interlinked pillars, I would say. First being community-based medical education. The second being community-based promotive and preventive mental health interventions. And the last being community-based participatory research or community-based problem solving. So basically what these terms basically mean is that under medicine beyond classroom, we try to develop holistic or complex interventions which include medical students, which include community-based research, and the intervention is targeted towards improving community-based is a community-based intervention to improve mental health. So within Medicine Beyond Classroom, our flagship program is Empowering Self while Empowering Others. It is a psychosocial competence building workshop series, which basically employs an older peer model. And we'll see what that means. And all the photos that you see are actually of the workshop being implemented through medical students of various different medical colleges. So this one particularly is being implemented in Anand district as a part of my residency at Pramukh Swami Medical College. So coming to the research title and proceeding as a research presentation, this was an awarded model at the Indian Association of Preventive and Social Medicine. And the research is titled Describing an Innovative Educational Intervention Integrating Community-Based Psychosocial Competence Building with Community-Based Learning and Practice of ADCOM Competencies. And this particular pilot was conducted at the Mahatma Gandhi Institute of Medical Sciences, that is MGIMS Wardha, and Dr. Sushila Nair School of Public Health, which is in Sevagram Wardha. And so the basic premise for this is that there are three stakeholder groups when we talk about this problem. So the first stakeholder group is our medical students. India has an annual enrollment of over 1 lakh medical students as of August 2023 across 704 medical colleges across India. And it is widely reported that medical students often face stress far in excess of their peers in the general population. And this might also be true for several other higher educational institutes. But we are focusing currently on medical students, and we have ample research to show that medical students do experience stress far in excess of their peers. And the idea is to integrate this issue with two other issues. So the second issue or the second group of stakeholders is our medical institutes. And so a lot of the people in the audience, I understand, belong to academia. And so they might know that a new curriculum was introduced for MBBS in 2019. I'll give some
we can't
context.
see your slides. We can't see your slides. Huh? Screen sharing has gone.
I'm resharing it again. Baba, I think it will be better if you can share the slides because the internet here is very weak. So I'm not able to.
Okay, let me try. Meanwhile, you can continue to speak when I am trying to do it.
Sure. Yes. So I'm just giving context before we proceed to the actual intervention. So the context, as many of you in the audience might already know, that the MBBS curriculum was largely overhauled in 2019. So a new curriculum, which is the competency-based medical education curriculum, was introduced for MBBS in 2019. And as a part of it, a new module was separately introduced, which is called the ATCOM module. The full form of which is Attitudes, Ethics, and Communication. So it's the Attitudes, Ethics, and Communication module. And the whole idea behind it was that it involves a lot of complex socio-emotional skills in the affective domain, which are very important, which are recognized to be very important for a physician to have holistic and healthy patient relationships, basically. Sorry. And traditionally, these are skills which are considered to be a part of the hidden curriculum, and it is expected that that students will learn it by simply observing their teachers, or will simply. So basically, we traditionally relied on students' own motivation for appropriate behavior, communication skills, and empathy with patients, and we considered this to be a part of the hidden curriculum. But since 2019, the ATCOM module was introduced to make this learning more formal. And however, since it's a new concept, at least in medical education in India, universities or medical institutes are largely struggling. And there are several research papers to back this, at least in the last 4 years, which show that medical colleges often struggle to implement this module effectively. Meaning that this module consists of case discussions or role plays, which are all happening across colleges in India. However, the effectiveness, which is how are we actually getting the results that we were hoping for with the ATCOM module? Are the students getting as engaged as we expected them to be while introducing the ATCOM module? So that remains a challenge till date. And the reason for this is that ATCOM competencies are very complex competencies, which include a lot of socio-emotional skills and things like ethics, communication. So it's difficult to teach it formally, and it's also difficult to evaluate or assess these formally. And so ATCOM module, though has been introduced, it is still a challenge with medical institutes to actually implement it effectively. So this is our second group of stakeholders. And the third group of stakeholders is our community youth or community as a whole. So India, as we are aware, has a large demographic dividend, meaning that more than a quarter of our whole population, or over 250 million people in our country, are actually youth in the age group of 15 to 24. In this scenario, as per the NCRB report of 2021, youth in India are facing an all-time high rate of suicides, which is very concerning. And in this, yes, Papa, this is the slide we are on.
Okay.
Thank you. And so considering that youth form such a significant part of our population and the suicide rates amongst these group is very high, it becomes even more important to know that our country largely lacks youth-led promotive and preventive mental health services. So it's not that it is not that we do not have provision for them, but these services are largely defunct. And so with these three problems which seem to be apparently disconnected, how do we develop an intervention which addresses all three at once? So next slide. The next slide. Okay. So no, Papa, the previous slide. Theory of change. So the theory of change basically, it's like in research studies that we conventionally do, we have a hypothesis. So when we are doing community-based intervention, or when we talk about implementation science, which is how to take evidence-based models into actual communities, we use the concept called theory of change. It is much more complex than I have portrayed here on the screen. But just for understanding the basic premise behind building this intervention, I've developed a very simple theory of change using if-then statements. So the idea is that if our medical students are trained to become youth peer educators as a part of their AdCom module, and these students then go out into the community to impart life skills education or psychosocial competencies to our community youth, then we stand to have threefold benefits. The first would be that medical students themselves are likely to improve their self-esteem beyond academics. They are likely to develop healthy coping abilities, and they are likely to develop overall psychosocial competencies, which we'll come to. The second fold, or the second layer, would be that the community youth stand to get a conducive environment to discuss personal, emotional, and sensitive matters for which they otherwise don't get a platform. And hence, they will also get a platform to at least start talking about psychosocial resilience, psychosocial competencies. And we would consider this to lie in the framework of promotive and preventive mental health, and not curative mental health. And the third stakeholder group, which is medical institutes, stand to benefit because they'll get a platform to implement AdCom module in real world settings rather than largely simulated settings which are currently being used, which is role plays. And we don't intend to replace those. We just intend to complement those, and we'll see how. Papa, next slide.
Yes.
Papa, could you also please mute yourself?
No, which I can't do because I'm sharing my screen. Probably I'm not able to do that. Anyway,
Okay.
I'll
No
try.
problem. Yes.
Is this?
Oh, yes, the objective.
Okay.
So the objective is to actually implement and evaluate a novel medical education intervention, which comprises of three things, which is administering the AdCom module in community settings by training medical students as youth peer educators. Second component is to train them as youth peer educators for imparting psychosocial competence education to community adolescents and young adults. As you can see, we are constantly focusing on three stakeholder groups while we discuss the challenges as well as the hypothesis behind implementing this intervention. Next. So coming to the methodology, this intervention was a collaboration between Medicine Beyond Classroom, which was a conceptualization partner, with the Department of Community Medicine, MGIMS Varda, which became the main implementation partner, and our community collaborators, which was a local government school and college. Papa, we are still on the methodology slide. Yes. So this is largely a descriptive study, and I would like to focus on this, that we have employed what we called is the transformative paradigm in mental health. So this is actually a topic for another discussion altogether. However, what it mainly means, transformative paradigm in mental health, basically just shifts the idea. So traditionally, mental health was also viewed with a very strong biomedical focus, meaning that in order to give importance to mental health conditions, as against just focusing on physical ailments, traditionally mental health conditions were diagnosed using a very strict biomedical model, just like we diagnose physical conditions. And this was done mainly, primarily only so that mental health conditions would also be recognized as actual ailments or actual pathological conditions. However, over the years, this is no longer a problem, which is that mental health conditions are now widely recognized as pathological ailments. So now it's the time to shift the way we view mental health and take into account the fact that mental health is very, very closely intertwined with a lot of socio-cultural determinants. And so we are now trying to shift our focus from biomedical model to a biopsychosocial model, which takes into account the integration of biology with psychology, which is how our mind functions and not just how our brain functions, and also taking into account the social aspects of mental health, which is our social environments, our family, school, neighborhood, workplace, everything. And so this is the transformative paradigm that we are trying to address, which is that we are trying to implement a holistic intervention in community settings or real world settings rather than being limited to just hospital or healthcare settings. The participants of our intervention belong to two groups. The first being the medical students, which were trained as peer educators, and the second group being our community youth beneficiaries. Next slide. So coming to the intervention description itself, next slide. This you can see is a photo of medical students sitting with community youth, and it's often difficult to differentiate the two, which is our point that community youth actually already include our medical students. It's not two separate populations, but our medical students form a subpart of the community youth. Next slide. So our intervention is a 20-hour workshop series, which is divided into 4 phases. Phase C, and it's a hybrid workshop series, meaning that some components of it are online and some components of it are in person or on site. So the first phase is actually phase 0, which is the introductory session. As you can see, this is online, and this largely includes me taking lead as the founder of Medicine Beyond Classroom. So this phase is largely handled by Medicine Beyond Classroom. And the idea is to introduce medical students to the concept of first human brain and mind development. Because these are medical students, we would also want them to learn something tangible from this intervention. So we don't just begin with socio-emotional skills, but we also talk about how the human brain development actually happens. We talk about the idea of neuroplasticity during adolescence. We use a lot of the research which is quoted in the UNICEF Compendium of Second Opportunity. This document basically describes how adolescence, and we already know this, but it describes wonderfully how adolescence is the second window of opportunity. So we all know how early childhood development works, especially in the first 3 or 5 years. But then this document focuses on how adolescence and young adulthood is actually the second window of opportunity, where our brain is getting molded or sculpted or shaped. And so this becomes our target audience to actually instill positive spirals or positive behavioral and socio-emotional patterns, which can actually pave the path for the entire life of an individual. So we explain these concept to our medical students. From there, we then move on to why it is important to build psychosocial resilience. We connect this with neuroplasticity, and we talk about how if psychosocial resilience building starts in adolescence and young adulthood, it can actually serve an individual well throughout their entire life, all through adulthood. And we then also discuss what community engagement actually means. And I would like to mention here that this program or this intervention is largely designed such that it can be integrated with community medicine curriculum, because within community medicine, students are already being mandated to go out into the field and interact with community during their field visits.
And so as a part of implementing the ADCOM module, we can actually implement it through community medicine curriculum. So the idea being that this intervention is not in any way an add-on to what is actually happening. It is just a different way to implement what we are already implementing. So there are no logistical issues which need to be taken care of additionally, because our students are already being taken out into the field through community medicine postings and field visits. So this becomes our introductory session, which is phase 0. Each session lasts 2 hours, and hence we'll see how it's a 20-hour workshop. Next slide. So as you can see, these are the 10 life skills. And in my previous talk at Saturday Club, I had discussed each of these life skills well in detail, but I'll just briefly review them. So the World Health Organization gives a framework which identifies 10 life skills or socio-emotional competencies or psychosocial competencies. It's a 20-year model now. It's a 30-year model actually. It was published first in 1994, if not earlier. It includes 3 clusters. One is coping and self-management, which includes self-awareness and coping with emotions and stress. The second cluster largely deals with social skills, which is how an individual interacts with their social environment. It includes competencies like empathy, effective communication, and building interpersonal relationships. And the last cluster is thinking skills, which basically involves skills related to identifying problems, thinking of various options, which is critical thinking, identifying options which actually work, and deciding to put them into action, which is decision making, and how to use all these skills together to actually solve problems. So these are the 3 clusters that we deal with. So in our intervention for each of these clusters, we now have 3 phases. Next slide. So for each of these clusters, we have phase 1. And so at a time, we focus on just one cluster. We don't combine 3 clusters together. We just focus on the one cluster. So for example, we'll take the coping and self-awareness cluster. So in that, we'll have phase 1, wherein we invite medical students as peer educators, because none of this can be mandatory. The idea is to give students autonomy, to make them feel that they genuinely are a part of the process, and this is not something compulsory that they are forced to do. And what we did observe was, after the first introductory session itself, 50 students volunteered to become peer educators. They were not forced into this at all. And the idea and the problem was that we ran into was that this was just a pilot study for us, and so we could accommodate only first 20 students, and then we continued this workshop or this intervention in MGIMS only so that we could accommodate all students who actually were interested. So initially 50 out of 100 volunteered to be peer educators, but we could train within this intervention formally we could train just 20. So this phase basically includes participatory design, wherein there are a lot of activities and discussions that happen around the life skills, which are a part of this specific cluster. And we train these students to become peer educators using what so a lot of you might be aware with this term. It is called participatory learning and action techniques. This basically means just activities which utilize a lot of visual diagramming in some or the other way to actively engage the participants, and through this we lead conversations and discussions around what otherwise might seem to be very abstract or non-tangible discussions, because these deal a lot with our experiences, emotions, and thoughts, and so it's good to have some visual diagramming around it. And so as you can see on the screen, on the image right in between, you can see a paper with some diagrams on it. So this session was also done online, and each of the medical student actually performs the activity on their own, like using a simple pen, paper, and some colors. And then all of get a chance to debrief. That is, they share whatever they've done in their activity, and this actually leads to further discussions about these life skills. And this is again facilitated and led by Medicine Beyond Classroom. Next. So once our medical students are trained as peer educators, they are then motivated. Again, the idea is motivated and facilitated, not forced. So it is possible that out of 20 students who volunteered, only 18 might want to go to the next step and 2 might not want to, which should be fine. But here actually we had all 20 who wanted and were very eager to go over to the next phase. And so phase 2 is that these trained medical students now go out into the field themselves and they lead the organization and they lead the organization of these community-based life skills education sessions in schools and colleges. So they contact schools and colleges themselves, they organize this session, and they also lead and conduct it. They are the ones who facilitate it now. And of course, they use the same activities which they had earlier participated in as a part of their training. So in this phase, they get to be leaders of change, and they conduct these activities with students. As you can see in the photos here, on the far right, you can see diagrams which are similar actually to the diagrams that you saw, the scribblings that you saw in the previous slide. It's because the activities remain the same, but the discussions can change because now this is community youth. These are not medical students. And so their age could be anywhere in the adolescent age group or young adult age group. So in our experience, a couple of sessions happened with younger peers, which is school-going children. But our medical students also led sessions with peers their own age or actually even a couple of years older to them. And this was all led by the students themselves. We did not guide them as to which age group they should choose. They just knew that they could target any age group or any section in the adolescent and young adults group. And they chose to address both populations, which is adolescents as well as young adults. And this implementation part was done in as I mentioned earlier, it was done in partnership with our community collaborators, which was a government school and college in the same district. Next slide. Okay. So after our students have conducted these community sessions, they come back to Medicine Beyond Classroom for a feedback and reflection session, wherein each of the students get a chance to share their experiences, just discuss and debrief. And this is done using the format of a focus group discussion, because this also serves as feedback for us. So this is part of the intervention because students get a chance to debrief and reflect on their experiences, but it is also weaved into evaluation of the program because the students give us, through their experiences, they are also giving us feedback about what works and what does not work in this intervention. So this is phase 3. And after phase 3 for one cluster, then we move on to the second cluster and we do the same 3 phases again, and then for the third cluster. And that is how the program is implemented over a period of 3 to 4 months, with the idea being that once in a month, we just cover one cluster. So we don't try to group these all sessions together. We, in fact, scheduling of this workshop series was also handed over to the students themselves. So it was handled by the peer educators or the volunteers themselves, and they came to us to say how they wanted us to schedule these sessions. And then the community medicine department kind of tried to integrate it with their ongoing community field visits. Next session. Next slide. Okay. So coming to the evaluation, we'll not go into the details of the actual indicators that we use. And honestly, we are also in the process of developing a more systematic evaluation for this program. But the main idea was to evaluate this intervention using a mixed methods approach. So we administered some pretty conventional surveys to our medical students as well as community youth. These questionnaires included largely objective questions, but then it also included a few open-ended questions. Then, as we said, we already conducted focus group discussions as a part of reflections and debriefing with the medical students. Then we also conducted informal debriefing sessions with the medical faculty, the resident doctors who acted as supervisors, and with the community school teachers as well. And we also, so our results are also heavily influenced by the observations and field notes made by the investigators themselves. That is by us. And our premise is that we can never say that we as investigators are not biased. All we can do is actually just be honest and very clear about our biases. And so as a part of our evaluation, we have formally mentioned that we as investigators will also use our own observations as one of as a crucial tool to evaluate this intervention. Next slide. Okay, so results and discussions. So coming to our some of the indicators of stakeholder engagement. So first is our medical students themselves. So as I discussed, 50% of them were very eager to volunteer as peer educators right from the first session. And so this kind of self-motivation itself seems to be very encouraging, and we'll see how it is backed by some literature as well. Secondly, the school, the community youth also, so we didn't do just one session, but we did multiple sessions at the same place. And so just like we gave autonomy to our medical students, the school teachers were requested to give autonomy to their students too. And so none of the students were forced to participate in these community life skills session. But most of the students not just participated once, but they participated in all the subsequent sessions as well. And they in fact wanted more sessions to happen. So this sort of a positive community engagement is also an indicator of why this intervention is at least acceptable to our communities. And the school and colleges wherein we implemented these interventions, they also requested the medical college to conduct more of such sessions. So again, uptake of this intervention was largely positive. Next slide, please. Okay. So coming to some qualitative data, because a lot of the data collected was, as I said, was collected through discussions and observations. So in discussions with medical students, the theme that came up very prominently was that medical students felt that this sort of an intervention led to their own socio-emotional growth. And this might look like a very heavy term to be used by medical students, but they actually said the following things, which you can see in the middle column. They said that it was life-changing for them. It was a cathartic experience. They learned how to be vulnerable, and they learned how to show empathy towards others who were trying to become vulnerable and share their own experiences. They also said that I learned to care for myself while caring for others. And lastly, they said something about their confidence being increased several notches simply by the experience of getting to lead a community intervention. So rather than sitting in a classroom and reading about community interventions in community medicine, they felt like they could also lead such interventions in the community. This is backed by literature which says, so it's a paper, it's a very interesting, okay, I'll come to that later, sorry. This idea is backed by literature which says that engaging youth in such mental health, in the provision of such mental health services to other community youth actually leads to their own empowerment. So the whole idea of our workshop, which is empowering self while empowering others, is actually evidence-based, because it says that whenever you get a chance to impart any sort of socio-emotional competencies to others, you actually end up internalizing them yourself. And so the whole idea of encouraging our students to become peer educators, our primary goal is to actually empower or lead to psychosocial resilience building of medical students themselves. Along with it, it also leads to more awareness of social and civic issues, which is completely in alignment with what the ADCOM module actually tries to achieve, which is it gives them, the medical students, a platform to see community outside of healthcare settings, because when our students see patients in the hospitals, there is often this power dynamic that they observe between their teachers and the patients that come in, and so our students end up modeling that itself, right? But in this scenario, the students are going out into the community and interacting with their own peers, just like they interact amongst themselves, and so they end up seeing these communities as human beings which are in no way inferior to them. So the whole idea is to develop a more nuanced socio-cultural perspective of our community, and become closer to the community which they actually intend to serve. Because when our patients come into healthcare settings, there is this invisible barrier or ceiling of hierarchy, even between a medical student and a patient. But in the community, when they are sitting on the same floor, sharing food and talking about life and sharing vulnerabilities, it is difficult for our students to not to view them as somebody who is inferior to them. So they end up viewing the communities as equals and collaborators to actually lead to positive healthcare outcomes. Next slide. Another theme that came up with our medical students was that students said that it increased their interest in the field of community medicine, which personally for me was a very humbling as well as very satisfying experience, because as I said, I'd begun medicine beyond classroom with the sole aim of becoming the brand ambassador for community medicine. So when I saw students give feedback, which is as you can see, they said that it is most fun learning experience that I've ever had, and that one student specifically wrote that we got to learn community medicine in the community. So which is medicine beyond classroom. And this is backed by literature which says, this is the article that I referred to earlier, which is Interest Matters. It is an article which is titled as Interest Matters, and it states how interest is a powerful motivation for learning, which should not be neglected. And so this intervention actually fulfills all four criteria for interest enhancement, which is first, attention getting settings. So these are unconventional or unorthodox settings. So they are attention grabbing. It is something new for the students to actually go out into the community. And every time they go out into the community, they are going to have new experiences. So it is never going to lose that attention getting aspect. Second, it does relate to individual context. So each student gets to talk about his or her own self. They get to understand the different contexts of their own peers as well as community peers. So it basically deals or relates to individual concepts, something that they can themselves relate to, something which is not a very distant thing, but something which actually affects their own routine life. The third was problem-based learning, because they go out into the community, they have to figure out a lot of logistics and not just how to conduct these sessions. They also need to figure out how to collaborate with community schools and colleges. They need to learn how to engage school students or college youth. And so one specific example that came up here was that our medical students had thought that only 25 school students will join in. But when they actually went in, 120 youths joined in. So initially, a lot of them were hassled, but they had no choice but to actually work as a team and manage the situation, which they did. And so this gave them this confidence that they too can solve real world problems. And lastly, they can see immediate utility value of their work. So when they conducted these sessions in schools, they were also the ones who collected feedback. And so they could see that the sessions or the activities regarding life skills that they were conducting with school students or college students was actually having a positive impact on the students. They could see that, because they could see how students were interested in having more sessions, how there were students who were initially hesitant to join in, and so they just kept lurking in the background. And when they saw that our medical students were conducting these very interesting activities, more students started to trickle in. And it was very interesting that the girls in the schools were very eager to join, and the boys kept just lurking behind. But eventually, all the boys ended up joining. So it was the boys also. So in our society, it is often considered that boys don't usually share emotional or personal matters. But in this scenario, when our medical students conducted these sessions, the boys were initially hesitant to participate, but they also ended up participating not just once, but in subsequent sessions. So this gave this increased confidence to our medical students, and it also increased their interest in the field of community medicine, because they could understand how medicine can also be practiced in the community and it has actual utility value. Something which might be of interest to academic audience today is that students under the mentorship of Medicine Beyond Classroom also published published in a student-led public health magazine. It was not a peer-reviewed journal, but rather a public health magazine. But this is just third-year medical students, and for them to come up with an article which can be published in any platform within a month seemed like a big achievement to the students themselves. Next. So these are just some quantitative indicators which we got from our community participants, which is more than 80% have consistently said that they enjoyed the sessions, they found this relevant, they intend to utilize, or not intend, but they feel like they are likely to use these skills in their routine everyday lives. Next. So it is the qualitative data which gives us even a richer idea of what the experience was for our community youth. So community youth said that they found the sessions very relevant. They found them comfortable because they reported that it was easier for them to share their vulnerabilities with somebody their age, which is our medical students, than with their parents at home or with teachers in school, which is backed by the WHO published literature, which says that peer education is a very effective tool. And it helped that these were medical students, because somewhere our community youth also look up to our medical students and a lot of school students actually look very aspirationally at our medical students because they also want to be doctors in the future. And so this kind of a respect for our medical students combined with similarity in age actually ended up becoming a very positive building a very positive environment for community youth, where they felt that they were getting a safe space to open up about their personal matters which are otherwise not discussed anywhere in their life. And so one student came up with this, that we often have difficulty talking about these things. We have no place to discuss these things. So this session actually gave them a platform to discuss these sensitive matters. They found the sessions very comfortable and safe. And they liked it, that they liked having participating in these sessions because no one discusses these things elsewhere. One person said that I'd never thought about it, but now I know that it is important to love myself. So as we can see, these are all very reflective ideas that are coming up from the community youth also.
If we can summarize in next few minutes, because
sure,
we want to leave some time for discussion.
Sure. This is the last slide actually. The next one. Yes. So coming to reflections or observations by the medical faculty, it was largely positive because they said that this seemed like a very utility conducive platform to actually implement ATCOM module in real life settings. And it was important for the faculty to know. It was an important learning for the faculty themselves when students said that this intervention was life-changing for them. So our faculty reported that for students to say that a class in community medicine was life-changing for them seemed like a big deal. And so in fact, we are in the process of understanding how we can include this intervention as a part of the regular curriculum. And our school teachers also also said that they would prefer that medical students collaborate with them more frequently to have such sessions across all schools as a routine part. And I think that brings us to the end of our session, and we conclude that this intervention serves as a potential platform for medical students to develop socio-emotional skills, learn ATCOM skills in real-life settings, while also benefiting the community youth. Our recommendation is that we need more research, more robust implementation studies to understand the actual feasibility and effectiveness of this intervention. Thank you so much.
Thank you, Dr. Chitra, for sharing your experiences of work in community and especially with medical students. So now the session is open for discussion. I see teachers like Dr. Nimisha Pandya here. Dr. Manish was there, but he has left. So any comments from Nimisha Ben or Jagdish or anybody, please. Dr. Jagdish, you want to say something?
Yes, please. Thank you, sir. Thank you, Dr. Pandya. And as usual, exemplary daughter of an exemplary physician, Dr. Pandya. So I had a few comments, Chitra. One is that it is a very interesting model, and I think it should be, rolled out for much more than just 20 students. I think if you are saying that there are 1 lakh students in India, you have to make a probable model which is replicatable across the country, because that is the most important thing. The second thing is, we also need to understand if there are any harms that come out of such programs, because students are generally not very mature. They don't have this, the skills of empathic listening. So some of them at least. So the problem is sometimes such programs may lead to harms within few people. So those also need to be evaluated. The third point I had was, see, the WHO life skill is a very interesting model. However, one thing which should start from the beginning is a mindfulness. That means that the student should understand what his mind is really all about. So maybe some kind of testing is required to understand whether there are any issues with his own belief systems. So that is very important. And of course, non-judgmental and empathic listening are skills that need to be taught, because this is a community-based program, and those are absolutely very, very important. The last point I had was, most of the medical colleges in the country have no department of humanities. And I've been working with the humanities division at the St. John's Medical College. And I think that's a very, very good way of students to understand the broader context in which they are studying medicine. See, for example, what does art have to do with it? What does dance have to do with it? And what have various other things like essay writing, like adventure writing. These are all part of humanities. And there are many doctors who, when they combine humanities with their medical knowledge, it gives a more rounded personality to these students. So I think these are some of the things that can be looked at also when you're doing such a wonderful program. Congratulations for doing such a very innovative program. I hope you can, mature it a little more and maybe spread it across the country. Thank you very much.
Thank you, Dr. Jagdish. Chitra, you want to comment on Dr. Jagdish's comments?
No, I just found these feedback comments very relevant, because especially the second one, wherein we are still trying to figure out how to assess the harms, possible harms of these interventions and how to mitigate them. And that is one of the major reasons why we are not suddenly scaling this intervention up to all students, because we first need to understand what are the possible risks and how we need to address them. And I've also noted the other comments, which also are very important. And I shall be discussing it again as soon as we have our next meeting to discuss the intervention with MGIMS.
Thank you. Any other comments?
Two things, Satish bhai.
Yes.
I very much agree with Dr. Chinnappa's suggestion, including humanities in medical education. First thing is, our 12 pass students are quite immature. By the time they become doctor also, I think their maturity level is not equivalent to what maturity level we have in medical students of US or UK or other countries. So it's very important that humanities are included in curriculum. 6 months at least should be taught for humanities. Another thing I would like to ask Dr. Chitra is, can you tell me exactly how you put this program in community? Suppose you take medical students to a school in a village, what would you ask them to do?
So, sir, this was, at least till now, it was largely student led. So, our medical students would come up with a list of possible colleges and schools that they would like to visit. And so,
Okay.
because MGIMS has a strong rural bias, which is they mainly engage their students in rural activities. The school that the students chose themselves were in rural settings. But if we had students who were not otherwise used to the rural settings and were going there, then we would have to include more contextualization and more sensitization to the students during their training as peer educators before they go into rural settings. So probably prior community medicine visits into rural settings would actually help prime them, rather than just directly sending them to settings which are very alien to them.
Any other comments?
Chitra, just a small one-liner, one thing only. I would suggest that if you can just get these 3 books, they might help you with your project. One is a book by Dan Siegel called Mindsight. Okay, this is a pediatrician who has written a very interesting book on how you need to understand your own mind before you do anything else. The second is a book on how behavior changed by a very famous neuro-linguistic programmer called Robert Dilts. This is on behavior change. And he says that behavior change takes place on 5 levels, and therefore you need to understand how these 5 levels can be fulfilled in any human being. And last one is a very interesting narrative, which is called as the sailboat metaphor. I've written on this. If you want, I will share the article with you, because the traditional model of looking at adolescents is the HEDES model. But HEDES model is only for assessment. It doesn't give you the intervention part of it. So I think the sailboat metaphor is a very easy way of a narrative which can help you with getting a storyline which the participants can then come up with. So these are some of the things that you can probably look at while you are designing your program.
Thank you so much, sir.
Thank you. Thank you.
So we end the session here. Thank you, Chitra, and thank you all the participants for very active listening and then interactions also. So we meet next Saturday morning again. Thank you all. Thank you.
Thank you, Satish Bhai. Thank you, Chitra, again. Wonderful session. Enjoyed it a lot.
Thank you so much. Thank you.